Brian probably doesn't need any further introduction at this stage, other than to say, and many of you would know this already, his blog is arguably the most popular, trusted and accessible beacon for 20,000 readers every month who have their lives touched by CLL. I work for the Sunday Tribune. I don't think we got that many readers during that time. His wife Patty is also with him today. The two of those, he and Patty founded CLL Society in the US. They both now work full-time endeavouring to educate and support CLL patients and their families. Patty is Executive Director of the CLL Society. They're going to share their unique, and Patty's going to share her unique caregiver insight. Brian is going to share his amazing story about entering trials for new novel treatments. In 2018, Brian, I know you took part in a trial, I'm hoping I'm pronouncing this right, CAR-T, Chimeric Antigen Receptor Therapy.
Yeah, well done.
Ladies and gentlemen, we kind of like to regard them as our answer to heart to heart. Brian and Patty Koffman.
Thanks. Yeah. So, as a physician, you always start a lecture with disclosures. So my disclosures here are, I'm here because I started on a clinical trial of a drug that just had numbers, didn't have a name. Phase 1, that's as early as you can get in a clinical trial. I have no detectable CLL by the best doctors can measure, down to 1 in 100,000 cells because of a CAR-T trial that I jumped into. And I have a bias towards expert care, towards novel therapies, clinical trials, and patients being involved. I'm also going to warn you that I tend to talk fast, have a lot of slides, and I'm going to go through it quickly here. So we're going to use one case, mine, to sort of teach about how to make the best decisions. We're going to talk about what a shared decision making is, how you're going to work with your doctor team. We're going to learn practical tips on self-advocacy. I'm going to leave some of that to Nick to cover, and I'm going to try to increase your odds of staying alive with CLL. So this is a picture that my son painted of me when I was first diagnosed to remember me, because I wasn't going to be around. And now it hangs up in our dining room as a remembrance of a different time. And this lists some of the things that I did to beat those odds. But as Michael already pointed out, anytime you see these statistics, they're always looking backwards. And none of these treatments were available at that time.
This was 2005.
Yeah. So the day you never forget, the D-Day, the diagnosis day. And this is what it looks like under the microscope, kind of boring. I had these enlarged nodes. I talk a lot about paradigm shift, and that's the diagnosis we all go through. Everything shifts in our life. We remember before, we talk about the new normal. This is my prognostic factors. You don't have to know all of these, but you know some of them now that you've heard about, 17P, 11Q. All of these are bad. These are my chances based on old statistics of staying alive. About 5% were my chances of staying alive for 5 years. But remember, this started in 2011, this data, which means the data started in 2006. There was none of these new drugs that were available, none of these new treatments. These are always looking backwards. So my lymph nodes grew. I grew a big beard, the advantage of being a guy, to try to hide my nodes. My patients were saying, "Are you okay, Dr. Koffman? What's wrong with you?" You know, my platelets dropped, and I had this terrible bruising and stuff like that. I failed all these therapies. I'm going to show a slide here very quickly to show, but I bled out, essentially lost half my blood internally. It was pretty awful. Then I suddenly got into remission, and my bone marrow went down from 90%, not as good as Jan's, but down to 6%, and my counts and everything got normal. My CAT scan still showed some enlarged lymph nodes, but not too much. And I went for a bone marrow transplant. That was the only potential curative therapy at that time, which is a bone marrow transplant is when you throw out your corrupted immune system. You have a lousy police force that aren't taking care of all the bad guys. You throw it out, and you say to a stranger over there, because I didn't have a sibling that matched me, "Could I borrow your immune system, see if it matches mine, put it in my bone marrow?" It's a transplant. It's like getting a new kidneys, except I get a new bone marrow. I get a new blood system.
That was 2008.
And I found someone. I went through the treatment. I started blogging on it. As you heard, the blog became quite popular. And this is a picture my son drew of me when I was going through this. If you count there's 7 different IVs running into me at any one time. This is me working out, trying to stay in shape, a cold washcloth over my head because of the side effects of the medications and headaches. Lost all my hair, and you can see I'm a child of the 60s with the Peter Max poster in the back. I relapsed. Now what to do? So I went to a conference in 2011, the American Society of Hematology conference, and suddenly there was a sense that the biology in CLL had been cracked, that it was no longer chemotherapy, which wouldn't work for me. There was an understanding that the CLL cells were addicted to a certain pathway. Their whole raison d'etre, their whole purpose in life is to communicate with other cells, and they do this through the B cell receptor, or BCR. And if you can block that BCR, if you can inhibit it, then the B cells, it's like knocking the, some of us in this room are old enough to remember when TVs had antennas. If you can knock out the antenna, they get no signal, and they don't work, and they eventually die. They don't quickly die. You're not killing them. They kind of slowly die off. And that's what happened. These B cell inhibitors, these B cell receptor inhibitors were born, and there was broad agreement. This was really exciting, so I jumped into another paradigm shift of how we treat CLL. I entered a clinical trial, and I'm alive today because of this clinical trial. I mean, no doubt about it. And this is the trial that I found. Clinicaltrials.gov is where you can find all of these, and they list international trials, not just USA. And I got a response that lasted about 7 years. And I'm going to not go through all of that, but you can see I'm traveling around the world and doing things, and was quite well. But eventually my CLL mutated around that. The drug that I took, PCI 32765, is now called ibrutinib, or Imbruvica. I jumped from that to another clinical trial. My wife is going to jump in here soon, which was a study for, and this is kind of fancy language, for CAR T cells, because I needed to do something more radical again to try to save my life. And I'm going to let you take over here.
Okay, our purpose and thank you to CLL Ireland for having us here today. Brian elected to have a treatment that is not a frontline treatment. CAR T therapy is for patients who have failed prior therapies. It's not yet FDA approved in CLL, although it is in other cancers. And we're hopeful that it will be someday. There's still, though the purpose of clinical trials is to help researchers get it right. So Brian went for this brave new therapy, and the results were wonderful. So we decided that we'd like to make our patient readership aware of kind of what the process is in a simple way. And fortunately, we have a son who's good at drawing cartoons and that sort of thing. So Brian and I wrote the dialogue here. Our son, Will Koffman, was the illustrator. And we're telling this from the point of view of the blood cell. So if you don't mind, I'll read the comic to you very quickly. All right. This is a story of change from exhausted T cell to life-saving superhero. The amazing transformation of CAR T. Hi, I'm a blood cell. In fact, I'm a special blood cell. I'm a lymphocyte. Not just any lymphocyte. I'm a T cell. I'm the captain of the immune system. I live inside the blood, bone marrow, and lymph nodes of a wonderful person, and I help protect him against germs and cancer. But my person seems to be sick. He has swelling of lymph nodes, indicating illness. My cousins, the B lymphocytes, or B cells for short, have grown too much. They're crowding out the bone marrow. They're leaving little room for healthy blood cells to mature. And they're making my person sicker and sicker. And this is affecting me too. I feel exhausted myself. I cannot do my work. I'm suspicious that these B cells are not behaving normally. Not only are they growing in the bone marrow and swelling the lymph nodes, they're all identical. They are clonal. They've quit doing their job as part of the immune system. They've become traitors to my person. They've become cancerous. My person has developed CLL, or chronic lymphocytic leukemia. And these new CLL cells are very clever at hiding from me. I need some help recognizing them. I am so tired. I think it's their bad influence, and I've let my person down. Wait a minute, I'm being pulled out of my person. I'm being spun around like crazy in a leukapheresis machine. And to add insult to injury, I'm being attacked by viruses. And they're inserting new messages into my DNA, my instructional code. Well, now I'm changed. I'm transformed. I'm focused, and I'm powerful. I am part me. I'm part another creature, like the ancient mythical chimera that was part lion, part goat, and part snake. But in my case, I'm part human and part virus. This virus is helping me to build a new receptor to recognize a marker on the surface of B cells. I'm recognizing now CD19. I'm a chimeric antigen receptor T cell, a CAR T, or CAR T, as I like to be called. And my new CAR has a target element, spacer, transmembrane domain, co-stimulatory domain, and signaling domain to supercharge me. And now I'm being stimulated to reproduce. Though I'm not inside a person, I am in the perfect incubator to grow. There must be millions of identical copies of me, and they keep checking on me to make sure I'm healthy. But where is my person? I'm still outside of my person. Unbeknownst to CAR T, back in his person, chemotherapy has been busy obliterating large numbers of competing lymphocytes through lymphodepletion to increase the safety of CAR T's imminent return. Weeks have passed. But wait, I'm on the move again. What's going on? I'm being injected back into my person. Oh, I need to rest after all this travel. I need to get used to being back inside my person's body. Sometime later. I've never felt stronger. I'm ready to grow again and be on the move. I have superpowers. Those cancerous B cells can't hide from me now. I know where they are. We CAR T cells are ready to attack. Bam, kick, bonk. It's a killing frenzy. Uh-oh, my person is feeling sick again. Maybe we overdid this. There's inflammation everywhere. Maybe my person is one of those who releases too many strong signals called cytokines to engage the immune system. Those cytokines, while helping kill the cancer, can make a person very ill sometimes, and this is called cytokine release syndrome, CRS. Sometimes CRS can make the person feel loopy or have trouble talking, or even have seizures, lose consciousness, and in worst cases, die from brain swelling. This is called neurotoxicity, but most people recover quickly. But now the drugs, steroids and tocilizumab, that are being injected into my person are calming all this inflammation. I'm cooling down. My person is feeling stronger. And most importantly, there are far fewer cancer cells, but my ongoing mission as a CAR T cell is to seek and destroy any stragglers until there are none left. And that's what I was programmed to do. I hope to stay around for a very long time, maintaining my surveillance to keep my person healthy and free from leukemia. The end. Thank you.
So you can't do CAR T without help with the caregiver. I was way too sick to have made decisions on my own. My wife had to say, I'm calling the ambulance, I'm putting you in hospital, I'm answering these questions, because I was completely out of it. I was hallucinating. I had a lot of these symptoms here. I mean, I was very, very sick. If you read my blog on the cllsociety.org website, you'll see what I went through. I was hallucinating. I was talking to monks in caves. I was in excruciating pain. I couldn't walk. I was bedridden. got a blood clot. I had to learn how to walk again with a walker, and it was a very difficult time. But when they restaged me a month later, there was no leukemia to be found. So, but there are side effects from all of this. This is not for everyone, and I have to tell you this. I went through this. I was very, very sick. I even wrote a paper on myself that was published in the medical journals to describe what I went through. There was another patient down the hall from me who didn't make it. And then there was another patient who didn't even get hospitalized, but his CLL got knocked back to deep, deep levels. So this is not predictable. This is new. I don't want to oversell this. This has tremendous potential, but it's not there yet, and it's not front line. I want to be clear.
And if you don't mind, there's something that I would like to say, and that is because Brian's blog and our website are looked at by a lot of people. We did put the word out basically around the world. If you have ever had CAR T therapy, please contact us. And we heard stories like Brian's story. But you know, it was very comforting because the person would say, they went through all of these side effects that Brian went through, but now they're playing tennis and they're back at work. So people do, the majority of people recover from this. But part of a clinical trial is to discover dose-related things and how to deal with side effects.
And also to talk to other patients who can give you a perspective, and that's what the advantage to CLL Ireland is. And make sure you talk to some of the staff here about connecting with them, because there's insights another patient can give you that your physician could never, ever give you.
That's right.
So I began blogging. We talked a little bit about my blog, and I began talking to other doctors. I always say leverage whatever advantages you have. I am a physician, so I'd leverage that advantage. I spoke at these international meetings of CLL patients and CLL doctors. We now average well over 50,000 page views a month on our website, which is ridiculous for an orphan disease. You saw the numbers, and have well over 1 million page views. And please take a look in the mirror here. I think you'll find I'm one of the most empathetic doctors around. Yeah. This is the website. It's been updated from this, but you know, there's a ton of good information here. CLL Ireland also has a very strong website that you can take a look at. There's our motto, smart patients get smart care. We've developed a toolkit. All of this is free and downloadable we'll talk about putting your team together. We talk about these words, these acronyms that you learn, that you've heard, like MRD, you've heard now, minimal residual disease. Now, but that's in there. If you hear terms like FCR, you might hear fludarabine, cyclophosphamide, rituximab, that's chemoimmunotherapy. It's all explained there if you don't know what those are. Normal lab values, spreadsheets, finding CLL doctors. We have a list of that. Some of our programs are all listed here. There's one that we're really proud of, which provides, and unfortunately it's only in the US, we're going to try to expand it, for people who can't get to a CLL expert, we provide them a free online virtual consult with top CLL experts across the USA. So check us out. We're there to help you. If you have questions, you can send them to us. We have a doctor who answers. We have a pharmacist, a lab scientist, a hospice person. We're developing financial aid people to help. So now I'm going to switch. I told you I talk fast and cover a lot of things. I'm going to switch, because I've told you my story. I'm going to talk about being your own advocate, how to save your own lives, and how to maybe help other people. And what I want to say here is that when you advocate for yourself, you advocate for others. There's no difference between that. If you're helping other people, you're helping yourself, and vice versa. That's really important to understand as you go through this. So there's things you need to know about yourself when you're entering this. You need to know a little bit about your cancer. You don't have to know everything. You need to know your own strengths and weaknesses. You need to own your own bottom line. There are some therapies that are 6 months and done. If that's what you want, then that's what you want, and you need to be clear about that. If you're willing to take a pill for years and years and years, then that's a different option. But that pill might be safer and have fewer side effects down the line. But these are important decisions that only you can make. Your doctor cannot make those decisions for you. You have to inform it. It has to be a shared decision. You need to know what's available to you, and different things are going to be different in other places. There are, sadly, and this is one of the things you got to work with CLL Ireland on, is that a lot of the options that I have are not available to you here in Ireland. You know, that's criminal in a lot of ways. There's fabulous treatments available in the UK. if you can get there, to get them. In Germany, in France, there's treatments that are available that aren't here. So these are things that you have to know about, of what's going on. You have to know about your insurance, what it'll cover, what it won't cover. I'm going to talk a little bit about self-advocacy and leave general advocacy for Nick, but the Institute of Medicine talks, there's a difference between being obnoxious and assertive. The most important, precious commodity to all of us, including physicians, is time. None of us have enough time. Your doctor would love to spend more time with you, but he or she doesn't always have that. So what I'm going to say here is to be clear and mention your most important question first. I won't tell you as a family doctor, I can't make this stuff up. This happens. People, as they're walking out the door, say to me, and by the way, that crushing pain I get in my chest when I climb the stairs, that's nothing, is it, doc? You know, and it's like, I spent the last 20 minutes talking about your toenail, and you bring up angina at the last second, you know? I mean, because they're afraid to bring it up. Don't be afraid, bring it up first. Bring your most important question you hear first. Be precise.
And I'd like to say something. I can't tell you how many times Brian and I went to his CLL appointment, and we would walk out the door and I would say, the doctor said to do, and he would say, that's not what the doctor said to do. So we would hear completely different things. I advise you to record your sessions with your doctor, or have your caregiver come with you and take notes, so that at the end, because it's a very emotional issue, and we don't always hear the same things. We sometimes hear what we want to hear.
So it's really important to have a caregiver if you can. If you don't have a caregiver, have a tape recorder. Yeah. So we talked a little bit about shared decision making. In the old model used to be your doctor gave you all the information, and then you brought your values to that and you made a decision. The new model is your doctor and CLL Ireland and the CLL Society and the internet and other people give you information. Support groups. Leukemia care. And national days like this of education bring you information. And bluntly, sometimes you have information that your local hematologist doesn't have, because he or she may see one other CLL patient that entire year, and you're going to be very up to date at the end of today and have information that he or she may not have. So now you bring those in and then you make a plan together. That's the model it should be. And bluntly, I've fired doctors, I've shopped for doctors to find ones that are willing to work with me and willing to work with a local expert. So I talk about building your team first, and that's the most important piece, and you need a CLL expert. There's survival advantage to having an expert on your team, and you do have a handful of experts in Ireland. Not a ton, but you're going to hear the number one expert, Professor Thornton, talk later this afternoon, and he has appointments available. So he is a top world expert, so you're blessed to have him, but you don't have a lot of depth, honestly, behind that. You don't have a lot of bench strength. You have time, but you don't have ever. I'm going to say one psychological thing, my Zen approach, underreact. You are definitely going to get bad news at some point in your CLL journey. Underreact to it, because it can change. You're going to get good news. Don't overreact to that. Just underreact to everything. This is a long, you heard life is a marathon, not a sprint. CLL is a marathon, not a sprint. You got to pace yourself. You can't overreact to all of these things. Forget about controlling your life. People, how did I get this? It's not fair. I eat so right. I exercise. Doesn't matter. You don't have any control over this. Every action, and even not doing things, people say, well, I don't want to do anything. That can be more dangerous than doing something. Sometimes if you need treatment, you need treatment. And if you wait too long, the treatments are less effective. So it's really important to understand even inactions. This one I highlighted. This is the most important piece of advice I can give you. You're going to have to make difficult decisions with imperfect knowledge and contradictory advice. You're going to have to make difficult decisions with imperfect knowledge and contradictory advice. When I went for my CAR-T therapy, I saw two of the top CLL experts in the world, two of the biggest names. I mean, award-winning CLL doctors, huge names in CLL. I got 180-degree diametrically opposed advice about what to do. One said, absolutely do CAR-T. Another said, don't do CAR-T. And I'm a physician. I'm supposed to make this decision. So expect especially at CLL, I said it's not like a strep throat where, you know, everybody gets penicillin or you don't get penicillin. You know, I mean, it's not complicated. CLL is complicated, and there's all these different options in terms of how to treat it. Think laterally. If there's a support group, support CLL Ireland. They're doing amazing work. Money matters. This is a very expensive disease to treat, but it's not, shouldn't be your whole life. You have family. A lot of us here have children and grandchildren. Enjoy them. Everything can't be about CLL every day. You know, you've got to live your life. You got to get forward. You got to get involved as volunteers and supporting other organizations. You get so much out of that. And we are really all in this together. We did a survey to test what patients wanted, and we published it at the American Society of Hematology. And we found that patients preferred, and now the studies from ASH point out that the patients were prescient. The patients saw the future. And the studies from the American Society of Hematology, the most prestigious meeting of hematologists in the world, found that targeted therapies like ibrutinib, and there's new ones coming, are the preferred treatment for nearly all patients. There is a small minority where their chemoimmunotherapy might still work, but it's only for a small group. And curative therapies may be possible, including things like CAR T or some new combinations that are in clinical trials. But the only way we're going to find out that they work is by joining in clinical trials. So the learning objectives were to use one case history, mine, and a recent online survey to illustrate how we make decisions, employ shared decision making, which I think I talked about, share a few tips about self-advocacy, and increase our odds of staying alive. And I do want to say, you know, one other thank you again, and that's to my wife, Patty, because I wouldn't be here without her. This is not a single journey, you know.
Thank you.
Yeah.
Thank you.
And I'll be available to answer questions about my particular journey and what's involved, but I wanted you to get a little excited about CAR T, but I didn't also want to oversell it because it's a very difficult therapy.
Thank you.